the invitation to speak today. It's really my pleasure to present this work on behalf of several of the investigators that were involved in this clinical trial. So this is paradoxical reactions to Olorofim therapy in patients undergoing treatment in a phase 2b study. And to just review real quickly, Olorofim, not currently on the market, but one we're really hopeful that is soon on the market. I think we've anticipated this for a number of years. This is a potent inhibitor of DHODH, and you can see really the pathway there on the right. You can think of this sort of like flucytosine. With purines, this is sort of more of the pyrimidine pathway. So it inhibits the pyrimidine pathway and appears to be fairly durable. Point mutations don't seem to develop during treatment with this like they do for flucytosine. So really a drug that we have been very excited to have on the market. We do have the same enzyme in humans, but our affinity for the same version is about 2,000-fold different. The human drugs that are used to treat the human DHODH are like leflunomide used for rheumatoid arthritis. So we do have sort of the same class to treat the human enzyme already on the market, but this one targets the fungal enzyme and doesn't appear to have a lot of cross-reactivity with enzyme inhibition. And then the spectrum of activity is really the piezo-mycotina. So it's hyaline molds and endemics. So things like resistant aspergillus, you can see this in the middle here. This is a patient from the Netherlands that had drug-resistant aspergillus, voriconazole resistant, treated with Olorofim, did very well by day 42. And then the one you can see there is an anastomotic infection from a lung transplant patient with scapulariopsis, also one that we really struggle with. Current agents are not effective for that particular pathogen. That Olorofim treated patient did very well. And then there in the bottom right is a patient with multiple cerebral abscesses from Coxey, did really well on Olorofim as well. So that really represents a spectrum of diseases we absolutely need new therapy for. And just to review this very quickly, Fariba presented this very nicely last year, a phase 2b study with 202 patients. And the patients in the study had refractory, resistant, or intolerant disease. And the primary and secondary outcomes were this day 42 and day 84 time points. And again, these are patients who really had no other therapeutic option. And a complete or partial response in 29% by day 42, 47% and by day had stable disease. And then by day 84, roughly about the same, 27% response, stable disease, and 36. The FDA views stable disease as failures. I think as clinicians, we view stable disease as satisfactory because most of these patients have cancer. We can get them to their next round of chemotherapy. And then it's important always to talk about how is this tolerated. It appears very efficacious. But we had patients in the study on drug for years. One of our patients on it for multiple, I think 3.5 years, and I'll talk about his individual case. And safety findings really do not appear to be cumulative. If they have an event, it's generally within the first 3 months. And hepatotoxicity is the one we care about the most for this study, something we really had to monitor for. 9.9% of patients had hepatotoxicity, and then other GI intolerance in about 2%. So that paper has now been accepted at Lancet Infectious Disease and will hopefully be out in the next 1 to 2 months, and you can really read that at your leisure. But one of the things we noticed during the conduct of this study was some of these patients, despite having overall clinical improvement, would have a paradoxical response to therapy. Some isolated symptom would all of a sudden worsen. And there really is a precedent for that in the literature. We see that with tuberculosis. We'll have patients who are significantly improving, and they'll have scrofula. They'll have a lymph node pop up in the supraclavicular space or elsewhere. And then leprosy, reversal reactions are very common in leprosy. And mycobacterial disease and fungal disease share a lot of the same pathophysiologic process. And so we had speculated during the conduct of this trial, when we started to see these paradoxical response, that this really may be a new syndrome that we'd not previously seen with fungal disease, and sort of put out a call to the other investigators to see if they're also seeing these cases. So when we pulled these cases together, the definition we used, we didn't come up with a new one. We just stole what was there from tuberculosis. So this paradoxical response is really defined as worsening clinical or radiologic findings following initiation of treatment, absence of any underlying disease worsening or relapse, and then absence of an alternative diagnosis. And again, just to emphasize, this clinically was not often difficult to differentiate because the patient's overall was better, but there was usually one thing that appeared to have gotten worse. And since these patients didn't have alternative options, we couldn't put them on a different drug. They were left alone. They were left on Olorofim, and these self-resolved with no change in their treatment. So I put this timeline here just to see some of the other paradoxical responses we see in infectious disease. Probably Gyrus Herxheimer is very well known. It's seen only in spirochete diseases. It's thought to be the death of the organism releases lipids in the cell wall. and your immune system recognizes those. So those are seen very early within the first 12 hours. We don't think that's what this is. And then you can see leprosy and tuberculosis have these different forms, and where you see these paradoxical responses depend on the type of disease, really, and the burden of the organism in those different hosts. So tuberculosis, those paradoxical responses are days to months after you start treatment. And then there's 4 different forms of leprosy. I've put 3 of them on here. Borderline tuberculoid, those paradoxical responses are 3 to 9 months. Borderline lepromatous leprosy is 15 months, and then lepromatous leprosy. And if you don't know what these are, like if you've seen Braveheart, remember William the Bruce, or what's his name? Bruce, his dad had lepromatous leprosy in the movie. So if you don't have a context for leprosy, maybe Braveheart will help you. But here's the patients that we observed in this study. So again, this is a very small number. So 202 patients total enrolled, and we only found 6 that met criteria. And I'll talk about the first 3 of these. But you can see 4 of these were female, 2 male, age really a pretty big span between 29 and 74. 4 of these had no host factor, just like a lot of our patients with really bad cocci don't have a clear underlying immunodeficiency. And then 3 of these were cocci, and then Scedosporium, Lamentispora, and Scedosporium apiospermum were the other 3 cases. These were pretty experienced, treatment experienced patients. You can see the cocci patients had a lot of antifungal therapy before enrollment with Olorofim. Again, this is a salvage study. And then the problem that we are going to have a hard time teasing out is the days of Olorofim prior to this paradoxical response. You can see that these range from 6 days to 253 days. So that's kind of why I put that spectrum of disease for the other mycobacteria, because I think it's very determined on the burden of infection, what type of this paradoxical response that these patients had. And then here's really what happened on the far right column there. One of the patients did have scrofula after he had almost a complete response. We were very surprised by this, and actually we were not thinking about cocci, and I'll talk about his case specifically. We saw vasculitic skin lesions. We saw inflammatory response around a sentinel lesion with Scedosporium. We had one of the patients with CNS cocci who had very stable failure for years. 6 days after Olorofim started, had sort of an acute worsening, which was very unusual to be stable for that long, stable failure, but then have an acute worsening and then to greatly improve thereafter. We saw sinusitis in a lung transplant patient, and then another skin disseminated disease with Scedosporium. And so to go through just a couple of these cases to give you more of an illustrative context, this was the first patient we saw. He's a 45-year-old African-American male, really had no other history, very treatment experienced, had about a year of sort of progressive failure through the azoles, ampho, and was even put on micafungin at one point before referred to us. Had progressive pulmonary disease, came in to see us, had a lot of cough, lots of bronchiectasis, and greatly improved. All of his pulmonary symptoms resolved. And on day 253, he had a new cervical lymph node, and we biopsied that, cultured that, found a granuloma with cocci present, but his cultures were negative. Really, again, we couldn't change him to anything else. We didn't think this was a clinical failure, so left him alone. All of his symptoms spontaneously resolved. And after 1,800 days of therapy, he actually was taken off. He's done great, has been observed for 9 months so far with no recurrence of disease. So he had really this more scrofula form of a paradoxical response. This was one of the more interesting ones. This is a 29-year-old African-American female, and she had no prior medical history either. She had widely disseminated disease, had brain disease, skin disease, and bone, heavily treatment experience, was sent to us from UCSF. Had clinical improvement really on all of her cutaneous disease and her brain lesions. And then on day 47 of therapy, came in with this sort of vasculitic rash. I even wondered if this was pseudoporphyria when I first saw her. We tried to get her biopsied. I didn't really feel comfortable biopsying over her knuckle or hand, so I was going to have dermatology do this. She said, no, I don't really want to do that. I'll be back. She felt well otherwise. I said, we'll just see how it goes. And over the next 2 days, she developed a new, very large pleural effusion, got admitted to the hospital for pigtail catheter drainage, was re-imaged. Her brain abscesses actually had new edema around those. And she was a little bit stubborn in some ways, and said, yeah, I feel fine. Leave me alone. I don't want any more treatment. Signed out AMA. So we just observed her, and all these lesions went away over the next 6 weeks. She was treated for about 680 days and then said, I'm done. I think I'm cured. We were like, we don't think you are. But she has proved us wrong. She's had a baby since then. Her child's now 3. She comes in for follow-up periodically, appears cured, but we actually wonder if this paradoxical response might have been a very favorable immunologic sign that she'd gained control over the infection. And she's been followed for about 3.5 years and really has no signs of recurrence. Her titers continue to go down. They're now down to 1 to 2, and I think peaked at 1024. And I know this is a cocci study group, but this is really an illustrative case. A lot of us see these other non-cocci fungal diseases in the hospital. This is a 74-year-old that was in Australia, had traumatic inoculation of C. diasporium. No prior treatment, was enrolled directly in Olorofim, and you can see what the lesion over the leg looks like. So had sort of an initial, between days 1 and 16, shrinking of the lesion from 4 to 3 centimeters. And then by day 35, increased in size, had more induration around there, and then a sinus tract also improved at the same time. So it had kind of this paradoxical response where lesion got larger and then finally shrank over time. And by day 225, really appeared to have near resolution of this lesion as well. So those are just 3 of the cases. I didn't want to go through all 6 because I think just time limits that. But the majority of these cases did occur within the first 6 weeks. We didn't see any hyperacute cases, which would have been like the Jairus-Herxheimer cases we see during treatment of spirochete or mostly syphilis for that. So we think this is probably driven by immune recognition similar to mycobacteria. And to steal from mycobacteria, since we don't have the pathophysiology of this worked out yet, it's generally thought to be an increase in IL-6 TNF alpha, decrease in TGF beta, increased Th17 cells, decreased Treg cells. And we do know from mycobacteria, a lot of them convert their skin test to positive. We didn't skin test these patients during the conduct of the Olorofim study. But from tuberculosis, they also enhance their T cell responsiveness in vitro. The lymph node, we actually do have a biopsy of that. So that's currently undergoing investigation to see if we can sort of prove some of this immunologically. So time will tell if we're successful with that. So to summarize this, we do think this is probably a newly recognized syndrome and has not been seen in the past because Olorofim causes rapid cell killing, rapid fungal cell killing. And the azoles are static, and AMPHO is kind of had some questions with that with cocci that the Mass General folks had presented a few years ago. These patients all lacked alternative agents. I think that's the only reason we really saw this is we couldn't put them on anything else. We were forced to just observe them, and these paradoxical reactions all self-resolved with no change in therapy. Even the 2 immunocompromised patients, the AML and the lung transplant patient, their immunosuppression was not changed. So this was not immune reconstitution inflammatory syndrome. So we do think you need a high index of suspicion. I think a lot of people would change therapy for these patients when they see some aspect worsening. And we would really caution against that with this recognition of a paradoxical response. The immunology, I think, needs a lot of work. We only have 1 biopsy from all of these patients. So something we can certainly explore going forward. But I'll stop here and just wanted to thank the other investigators that had seen these patients and for contributing to this report. So thanks so much, and happy to take questions.
Any questions?
In the course of the clinical study of Olorofim, were there other cases that looked like this that turned out, that is to say, worsening after initial improvement that turned out to be drug resistance? How would you try and separate them if that has been occurring?
So we did not see the development of drug resistance in any of the patients that I'm aware of in this study. We had a few patients that we had sort of, slow responses. So we'd said, well, maybe they become resistant, and we'd sent those isolates off, and they did not. There's no in vitro resistance, I should say. So I think, there's only 6 patients, so we need a lot more work on this. But I think it did cause a lot of consternation taking care of these patients.
Thank you, GR. This reminds me also that we may be missing this in patients treated with the standard azoles. It reminds me a little bit when I first got into cocci that my former colleague, Dr. Smilak, told me that when people were doing worse, just sit tight and they'll do better again. And sure enough, he was right. But how long do you think we should be sitting tight before because we just are pretty quick to whip out another azole?
Yeah, I totally agree. Everybody that attends in the hospital knows that a team can't tolerate a fever for 12 hours. So they call us and we're like, nope, their bacteria still are not dead yet. So, I think this was somewhat serendipitous. We even noticed this because we couldn't put them on anything else. They'd failed everything. Right. This is a salvage study. And I think that there's a lot of wisdom just with the oldest attendings in the hospital. They're often the ones that say like, don't do anything, stop everything. I think there is a lot of wisdom in that. It's hard to do without a lot of experience. But I do think for these patients, the biggest key is that they clinically were better. They had one aspect. They kept saying, I feel so much better. Just ignore this lymph node. We're like, no, we're not going to just ignore it. But I think that's what made it easier is they felt so well despite these other things sort of flaring up. I do wonder how often we miss this just in general because patients are often at home. You know, we do see sometimes we start patients on therapy and their titers still go up. And I've always wondered, well, are we just blunting their titer that was going to go to 1 to 32 and it's now gone to 1 to 16? I don't know. But maybe it's release of some of the antigens, et cetera, that cause those symptoms. I mean, your paper is one of my favorite ones ever. It's an EID, Janice, about the treated patients and their 9 cardinal symptoms versus the non-treated. And I was always struck by the treated patients had more of a bimodal curve in symptoms and the non-treated patients didn't have that. And I'd wondered, is that from the fungal death? Is that from the drug? Is it suppressing the immune system? I don't know. But it's created a lot of these questions with therapy and how we follow these patients longitudinally.
We're going to need to hold the questions. Find you at the break.
No worries.
Jing Chen, comparing diagnostic values of fungal flip-flop sign versus serology and FDG avid pulmonary nodules in coccidioides endemic regions. So we're making some adjustments here as we go.